Next, we are going to hear from Dr. Kupfer and considerations for pulmonary care. He is an associate professor in pediatric pulmonary medicine and inpatient medical director of Breathing Institute, Children's Hospital, Colorado. His clinical interests include treatment of children and young adults with neuromuscular disorders like Duchenne, SMA, congenital muscular dystrophies, and congenital myopathies. He's also interested in designing medical guidelines, education, and communication tools that allow children with complex respiratory needs to receive high-quality individualized treatment wherever they go. So thank you for being here, Dr. Kupfer. You can go ahead and share your screen.
Thank you for that wonderful introduction. A lot of those words I wrote myself a few years ago, and I really do mean them. I love taking care of these kids and young adults, and I really do enjoy focusing on making sure that everyone's on the same page in terms of understanding what their disease is and what we can do as a medical team across almost any institution to take care of you or your child. So I'm going to launch in here. So here's a little outline about what we're going to talk about, really 4 areas. One, breathing requires muscles, and we'll go very briefly over the muscles of breathing and how they function. And I'd like to talk a little bit about patterns of respiratory muscle weakness, because not every neuromuscular disorder is the same in terms of breathing. We'll go over pulmonary function tests and other tools that we use in the pulmonary clinic when evaluating patients with muscle problems. And then we'll talk a little bit about treatment modalities and what we do about those muscle problems. This talk is going to be a little bit generic because we have to cover a wide variety of neuromuscular disorders. And so I'm not going to provide a huge amount of detail on any one diagnosis, but I think the common themes, I should say, will come through. So first, let's go over normal breathing. So this is a cartoon of the muscles of respiration. And essentially, we have to deal with 2 phases: inspiration, or taking air in, and expiration, getting air out. The muscles of inspiration are mainly the diaphragm, which is the domed muscle at the bottom of the chest that separates the chest from the abdomen, and it contracts to draw air in. There are other muscles of inhalation as well, the external intercostals and the accessory muscles. So I don't know if you can see my cursor, but the inspiratory intercostal muscles here between the ribs, and then the accessory muscles here at the top of the chest that pull out and up when we need to take a larger breath than just a normal inhalation. Exhalation is mostly passive when we're just breathing at rest. But as soon as we want to control our breath, laugh, scream, cry, breathe out for a longer period of time against pressure, we have to use muscles. So while in medical school we learned that exhalation is passive, there's no muscle contraction, that's not really true. What I'm doing right now is using expiratory muscles in a very controlled way so that I can project my voice into the microphone and to you. And so we need these muscles that compress the chest, and these are the internal intercostal muscles. So these marked in green here that push the chest in and up. And then also the abdominal muscles, you can see a little bit down here at the bottom, but really over the belly that push the chest upward to force air out. So it's really two phases, each requiring several sets of muscles, and disorders in any of these muscles or all these muscles can cause breathing problems. So normal breathing is really a balance between the tendency of the lungs and the airways to collapse down and shrink, and the ability of the respiratory muscles to hold that system open, and the chest walls force outward. So if we think about the ribs as coils, they want to expand outwards and straighten out. What happens in neuromuscular disease is that we lose those respiratory muscles, and the tendency to collapse outweighs the tendency to expand, and we get small breaths and difficulty breathing. So in summary, and this is a slide courtesy of Dr. Mayer at Children's Hospital Philadelphia, we have respiratory muscle weakness, which we can divide into diaphragm weakness, chest wall muscle weakness, and spinal instability because we have to be held upright in order to breathe well. Those disorders lead to poor airway clearance, the inability to get mucus out, and we'll talk more about that. The chest wall dysfunction, meaning that we can't expand and contract the chest as we desire to. And then kyphoscoliosis, so postural changes and position changes that affect breathing. Those issues lead to pneumonia and low lung volumes, which have an interplay between them. And then pneumonia can lead to muscle fatigue, especially diaphragm fatigue, and an increased respiratory load, meaning it's harder for those muscles to work because now they're fighting an infection, but they're already weakened, and so you get into this vicious cycle. Low lung volumes also put the muscles of breathing at a mechanical disadvantage, so it's harder to expand the chest when you really contract it down. And those ultimately can lead to respiratory failure, and that's really what my job is to prevent respiratory failure, potentially prevent diaphragm fatigue, respiratory load, pneumonia, and low lung volume. So if I can get us back up to just having some muscle weakness that we support, I've done my job. Okay, so that was it. That was basic physiology of respiratory muscles very quickly. So I'm going to move on to patterns of respiratory muscle weakness. And I'm just going to talk about different themes. So as you all know, probably better than me, the natural history of respiratory diseases really varies by what you've got. You can think about presentation as being variable, so the respiratory muscle weakness can be variable even within the same genetic cause, and we see that with spinal muscular atrophy. We see that with RYR1 congenital myopathy. We see that with collagen 6 and Nemelin myopathy. All these different disorders all have a very variable presentation based on factors aside from genetics. We can also predict some. We know generally what SMA type 1 looks like. We know generally what Duchenne looks like, but every patient is going to be different. Other disorders are quite episodic. The one that comes to mind most easily is congenital myasthenic syndromes, but a lot of the congenital myopathies can also have episodic dips in respiratory function with infections that then return to a better state afterwards. Some disorders are static. They tend to be about the same all the time. Some progress, and some actually, and I didn't write this here, some actually get better. And so knowing the diagnosis can sometimes help you understand where your breathing might be going. And then in some, that progression is predictable. Thinking about Duchenne, collagen 6, we have some very nice natural history data on those disorders and some others. And then progression in others is very unpredictable. And so I don't know how to prognosticate. I don't know how to tell you what may happen in the future. And so we have to understand that we're going to go on this journey together. This is a slide that I usually give out to my pulmonologist colleagues who don't do neuromuscular care. And I tell them not all neuromuscular diseases are made equally poorly. They all suck, but I'm just going to say that. But understanding where the muscle weakness comes from actually helps us understand what might be going on. And we'll see some cartoons of that a little bit later. So I think about symmetric versus asymmetric muscle weakness. Do you have more inspiratory muscle weakness or expiratory muscle weakness? Even if they're both weak, is one weaker than the other, relatively speaking? Because that can have an impact on, say, how we position a patient to optimize breathing, and what kind of interventions and when we use those interventions are needed. As I mentioned, positional changes can be important. Some patients, based on their pattern of respiratory muscle weakness, do better lying down than sitting up. Others very much do better sitting up rather than lying down. And that has a big impact on what we do and how we take care of patients, both long-term when they're stable, and especially when they're sick in the hospital. In the ICU, they love to sit people up. That's important for a variety of reasons, and for most people without neuromuscular conditions, that does help. For some with neuromuscular conditions, that will harm their breathing. I'm talking mainly about those with more expiratory muscle weakness than inspiratory muscle weakness, especially someone like a very weak spinal muscular atrophy. They are better off laying down because of their mechanical issues with their respiratory muscles. And that's something that we need to know so we can take care of you. There are definite differences in wake versus asleep. Some disorders, most disorders honestly start with sleep disordered breathing rather than daytime dysfunction. But there are few that actually have a huge discrepancy between respiratory function when awake and respiratory function when asleep. The one that comes to mind most easily is Selenon or 7 related muscular dystrophy. But we also see this in Pompe disease and a few others. And then some patients can actually be ambulatory with respiratory failure. That's not what we usually think of. We usually think of someone who's non-ambulatory, who can't walk, have progressing to respiratory failure. And that's kind of the Duchenne model, and that certainly works in Duchenne, but it doesn't necessarily work in other disorders. The one that comes to mind most there is actually Pompe, but there are others as well. So it's really important to know the diagnosis, for me to understand what that diagnosis means, and then tailor respiratory care to that diagnosis. So here's a table from an article that a colleague of mine at Stanford published a few years ago. And this on the left lists a wide variety of neuromuscular disorders and then different features of them. It's not important to find your disorder in here. The point is that each disorder has its own characteristics of respiratory issues in terms of onset, frequency, timing, progression, or no progression. And so this is kind of something that I have to be thinking of, and every pulmonologist should be thinking of when they meet. Okay, so let's go on to pulmonary function tests. So there are essentially 4 pulmonary function tests that we do in the clinic. The first one is vital capacity. How much air can I blow out after taking my biggest breath? So we fill the lungs as much as we can and then blow it all out. And when we do that in a forced way, it's called an FVC, a forced vital capacity. When we do it in a relaxed way, but we still get all the air out, that's called a slow vital capacity. Really what I want to know is how much air is coming out after you fill your lungs completely. And that can tell us how expansile, how compliant the chest is, and how strong those muscles are in a total system. The next 3 tests try to get a little bit more at specific muscle function. So the peak cough flow or cough peak flow, depending on who you talk to, is a flow rate. How fast does air come out when I cough? And it's really that maximal flow. So right when I first cough out, how much air or how fast does that air come out? It's not how much, it's how fast. And that rate can help us understand if you have an impaired cough function. Those values are really normalized for adults, and we tend to bring them down into roughly 14, 15-year-old range. Before that age range, so for infants and school-age children, we really don't have normal values, so it's hard to interpret those numbers. The next 2, the expiratory and inspiratory pressures, really isolate the expiratory and inspiratory muscles. And so these can be very valuable tools. So essentially all we have patients do is blow out after taking a big deep breath. They blow out against a closed valve, and we measure the pressure against that valve. That's the expiratory pressure. So how hard do my expiratory muscles squeeze? And then we do the exact opposite for inspiratory pressure. We exhale completely and then suck in as hard as possible to measure the inspiratory pressure against that valve. And that helps us understand how strong are the inspiratory muscles. So now we're really doing muscle tests, kind of like your physical therapists or neurologists do, but for the respiratory system. The MIP and MEP can be low or declining before we see a change in vital capacity. And that's really important because those are early subtle signs that we may have some respiratory muscle impairment. All of these tests are volitional. They require participation. And so if we're too young, or we have cognitive issues, or we can't form a seal on a mouthpiece like in the bottom right, or with a mask like in the 2 pictures on the left, then these results can be skewed. And then finally, as shown in the top right picture, we can also measure these tests, especially vital capacity, in different positions. And that also tells us something about respiratory muscle weakness patterns, right? So the picture on the top right is the only one I could find on the internet of someone laying down doing pulmonary function tests. I promise you we don't make our patients hold the device themselves. We'll do it for you. But if you have a vital capacity upright and then laying down that differs by 20%, that suggests that the diaphragm function is impaired. So that's another inspiratory muscle test. So we can use position to understand how your muscles are functioning as well. There are additional tools. Of course, we can use chest and spine x-rays to look at how the lungs are inflated and is the spine curved. We can use blood gases to measure CO2 levels. What I didn't put in here is, of course, we look at oxygen saturation levels, but that's a very basic test that is done in every clinic. CO2 levels are a little bit more specialized. We can, of course, look at sleep studies and swallow studies to look at what's happening to breathing during sleep, and is there an element of aspiration or lung injury from food going into the lungs. Okay, so let's get to mechanical therapies. So remember, without respiratory muscles functioning well, our tendency is to collapse rather than expand. The idea with mechanical treatments is to reset that balance so that we have a balance between collapsing and expansion. That's the whole idea. That if you had to remember one slide from this, my goal is to be your mechanical treatment. So one of the mechanical treatments we have is cough augmentation, how to get mucus out if you don't have the respiratory musculature to do it. And I like to think of this as an ounce of prevention as opposed to a pound of cure, right? So we can use this as a preventive method in cases of neonatal weakness, most commonly the severe congenital myopathies, including myotonic dystrophy and Nemelin myopathy and all sorts of others, as well as in spinal muscular atrophy. We can also use it preventively if we see that the chest wall is underdeveloped or has a chest shape that is indicative of respiratory muscle weakness patterns, because we can inflate the chest and improve the mechanical, kind of the shape of the chest to allow dysfunctional muscles to work at their best. And then there are some cases in which we know disease progresses, such as in Duchenne muscular dystrophy, where at first you really don't need cough augmentation, but at some point you will. And so we need to have objective measures of when that might happen. And so we use this third box for all respiratory, or for all neuromuscular disorders, but the data mostly comes from Duchenne. So this is when your vital capacity is at or about 50% predicted. If your peak cough flow is less than 270 liters per minute, or if your maximal expiratory pressure is less than 60 centimeters of water pressure. And then, of course, even in the absence of these numbers, or if we can't get measurements for whatever reason, if you have recurrent or frequent chest infections, that's an indication enough to start mechanical cough augmentation. So what do I mean by mechanical, excuse me, what do I mean by mechanical cough augmentation? Priority number one is to improve cough function. And we do that with, the technical term is MIE, mechanical insufflation exsufflation, but we commonly use the phrase cough assist. Right? Cough assist is actually a trade name of a specific device, but when I use cough assist from here out, know that I mean, generally speaking, mechanical insufflation exsufflation. That really comes in three phases. This is a device that fits over the nose and mouth, blows air pressure in to give that big breath like you're going to cough. And then what we're supposed to do is contract our expiratory muscles to try to squeeze out. And then the device delivers a negative pressure to pull air out, just like we're blowing out. So that's absolutely priority number one. That's the mainstay of therapy for a weak cough. If that's not enough, we can do other things for mechanical mucus clearance, like manual chest physiotherapy, so pounding on the chest to loosen up mucus. We can use a device called IPV, intrapulmonary percussive ventilation, that provides some inhalation pressure and then vibration to shear mucus off the airway wall. We can use a vibrating vest like is done in cystic fibrosis, and that also shakes mucus off. And then, of course, in the worst circumstances, we can use bronchoscopy, where I take a camera into the lungs and try to pull out mucus. There are also medications for mucus clearance, but again, these should only be used in conjunction with a cough assist device. So there's a number of different medications listed there. Most of those none of those were developed for neuromuscular disease, but as pulmonologists, we try to borrow from any knowledge we have from other disorders to see if we can help you out too. Okay, so I explained a little bit about what mechanical insufflation exsufflation is. It comes in three phases. There's a positive inflation pressure, a negative suction pressure, and then a pause until the next cough. So it's not just going in, out, in, out, in, out, in, out. It's in, out, pause, in, out, pause. This can be delivered by mouthpiece, by mask, by a breathing tube, tracheostomy. There is just about no reason to not use. There's no reason to avoid cough assist. How's that? Almost no reason. If you have an opening to your airway, I can do cough assist. And this is absolutely the preferred method of airway clearance for respiratory muscle weakness. All those other things, inhaled medications, vibration, all that, won't help if you can't expel the mucus. So here's just a quick example, publication out of a medical journal, Chest, several years ago. This is a little baby with, I believe, spinal muscular atrophy, who on the left has a pretty socked in right upper lobe pneumonia here. And you can see after some sessions with cough assist, that's cleared up nicely. They've managed to get air behind that mucus and then pull it out with cough assist. The other thing that's notable here is that there's no breathing tube. So this child was never intubated. This was all done non-invasively, which is really cool. So we don't have to be intubated to do this effectively. And believe me, this baby was sick. You can tell from all these other things that this child was in a medical facility and probably in the ICU. Okay, so let's move on to a more long-term support rather than just episodic cough assist support. So when do we start respiratory support? So before I even go there, it should be stated that oxygen is never the answer. If someone with a neuromuscular disease has low oxygen, we have to ask ourselves, why is there low oxygen? The most common answer is there's something in the lungs, we need to get it out. Or this patient can't take a deep enough breath to draw in enough oxygen. So just giving them oxygen does not solve the problem. It either just bypasses the mucus obstruction that we need to get out, or it doesn't deal with the mechanical issues of I can't take a deep enough breath. So oxygen doesn't treat the underlying cause, and therefore it's likely to get worse. So this is really about BiPAP, about non-invasive ventilation. When do we start non-invasive ventilation? So if we have signs or symptoms of impaired sleep, and those who come to my clinic know that that's the majority of what I ask about. Do you snore? Do you sleep restlessly? Do you sweat? Do you have morning headaches? Are you fatigued during the day? Are you falling asleep in your stoop at night? All those kinds of things. At the time of diagnosis for SMA type 1, that's a little bit old because now we have in many places newborn screening where we can be aggressive about treating. But we also start non-invasive ventilation at the time of diagnosis for any neonatal respiratory or any neonatal neuromuscular disorder that has a respiratory component. So it really shouldn't say SMA type 1, it should say any neonatal onset weakness. If you have recurrent pneumonias or persistent coughing, it's quite possible that as you sleep, the chest deflates even more because we all have lower tone during sleep, and so you need a bigger breath, and that can actually help with recurrent pneumonias. Same thing with recurrent respiratory hospitalizations. And then another really important thing that I pay attention to is nutrition. So if you're burning all these calories because you're working too hard to breathe during sleep, BiPAP can take that load off of your respiratory muscles, and with the same calorie intake, you might actually grow or maintain a healthy weight. Objective measures of when to start BiPAP. Again, this mostly comes from the Duchenne literature, but we use this broadly. If your vital capacity is less than 50% predicted, The inspiratory pressure, how hard you can suck in, is less than 60 centimeters of water pressure. If your oxygen at sea level is less than 95% persistently, in altitude you get a little credit, but I don't give you that much credit for being at my altitude. If your CO2 measures awake are over 45 millimeters of mercury, so just a little bit elevated, you probably deserve BiPAP. And then of course, if you have a sleep study showing any breathing disorders like high CO2s, hypoventilation, low oxygen, fast breathing, or poor sleep structure that may be interrupted by sleeping issues or respiratory issues, you get BiPAP. So the goals of BiPAP during sleep are to provide respiratory muscle rest. That provides you a nutritional benefit. That also provides you a potential airway clearance benefit. We want to synchronize breathing with the machine, so that means we have to get the settings right. And we want to provide chest wall expansion. Again, that puts the respiratory muscles in a better mechanical place to function as best as they can and can prevent respiratory infections. BiPAP for neuromuscular disease requires a strategy that's just for muscle weakness, and it's different than sleep apnea. And that's sometimes difficult to convey to a sleep lab when they're titrating BiPAP settings. BiPAP in neuromuscular disease has to give maximal support for breathing effort. It's not just to overcome upper airway obstruction like guys like me have in obstructive sleep apnea. And then you have to have a backup rate. Patients who are weak often don't trigger the machine to breathe for themselves, so the machine has to have a metronome in it that says, this patient didn't take a breath, I'm going to give one. That's different than the obstructive sleep apnea world. Okay, so another way of thinking of ventilation, so we have pressure and time on this graph, and then we have one single pressure going across all the time. That's called CPAP. It's a single continuous pressure. BiPAP is a little bit different. We have a lower pressure, the expiratory pressure, and then when you inhale, you get a bigger pressure to deliver a breath, and then it goes up and down over time. That's called biphasic positive pressure, or BPAP. Here's the trick. Don't use this in neuromuscular disorders. Don't use CPAP because it doesn't help you inhale. And part of your respiratory muscle weakness is the inhalation. So CPAP really doesn't help people with neuromuscular disorders. It doesn't help you take that breath, that deep breath that you can't do because of muscle weakness. Here's a different way. So this is a cartoon of a specific pattern of respiratory muscle weakness. This is where the diaphragm is relatively stronger than the other muscles of inhalation. So this is what a normal chest would look like at rest if you just, at the end of exhalation. On the left, we'll have a side view labeled as you see, and on the right of the screen, you have a frontal view of the chest. So what happens when someone with a preserved diaphragm inhales? The diaphragm comes down, but the chest can't withstand that downward pressure, and it sinks in, and you get this sunken in chest shape, which in medicine we call pectus excavatum. And you see the chest gets long and narrow, and the belly pops out on the sides. Then when they exhale, the diaphragm comes up, and you actually get a wider chest. So it's this paradoxical chest shape change where the chest should get bigger when you inhale, but it actually gets bigger when these patients exhale. Okay, why did I do that again? Okay, so let's talk about what happens with non-invasive support. So let's go back here. So this is, again, end of exhalation, normal exhalation. If we just give you CPAP or the expiratory pressure of BiPAP, remember the diaphragm isn't contracting at that point, either because it's dysfunctional or because you haven't started inhaling yet, right? So I put you on a little bit of CPAP. And EPAP means expiratory pressure. The diaphragm hasn't contracted yet, and the chest may gain a little bit in size, but not a whole heck of a lot. Then you inhale, the diaphragm contracts, air pressure is delivered, and you get a nice expansion of the chest to get a bigger breath. You exhale again, go down back to a normal chest size, and then when I take BiPAP off, you lose that small expiratory pressure, you deflate a little bit more. So that's the idea. We have this really abnormal chest conformation when we inhale and exhale with respiratory muscle weakness. BiPAP tends to overcome that. Okay, so that's kind of nighttime breathing support. When do we start daytime breathing support? Well, usually we have to lose a little bit more lung function. So vital capacity around 20% is when daytime support is often needed. Or if we see an elevation of CO2 during the day, that means we're not keeping up with our ventilatory needs during the day. Or if we have daytime fatigue or shortness of breath. So I ask my patients very simple questions like, say the alphabet for me, and I just count how many breaths it takes to get to the end. That's not a validated test, but it's a way of seeing how short of breath are you. If you're using cough assist a lot because you're trying to get that breath in all the time, it feels good to expand your chest. Well, there's a better way that I can do that. We can use daytime breathing support. And then the big one that I've seen is speech augmentation and volume support. So before this crazy pandemic, I would ask my teens and young adults with Duchenne, can you talk to your friends or your family over a loud movie? Or if you were I take care of the adults too, if you're in a bar, can you be heard? Can you join the conversation? They often say no. I say, watch this. Let's try some daytime breathing support. And it really helps the volume of their voice get better, and they seem happier because they can participate in life again. So how do we deliver daytime breathing support? We can do it any number of ways. Through a nasal mask, just like your BiPAP. We can use a sip and puff ventilation method, which I think I have pictures of next. And we can also use a tracheostomy. And we have to remember, tracheostomy is a tool. It's not a bad thing necessarily. If it helps you meet your goals, then okay, that's a tool that we should talk about. If it doesn't help you meet your goals, okay, that's not a tool we need to be discussing. It's not good or bad. It's whatever it can do for you. So here are some pictures of interfaces. There's nasal interfaces like this lovely girl here and this lovely young man here. There's also mouthpiece, which you can see in the top right corner here. So that's non-invasive, not surgically attached. That mouthpiece tubing goes back to the device that's mounted on the back of the chair. I've crossed out full face mask. That means covering the nose and mouth. And that's because I think especially for people who can't reach up to their nose or mouth can be very claustrophobic and definitely limits communication as well. I also worry about people who might get upset stomach from air going in, having to throw up. There's no way for the vomit to get out, and it could get pushed back in, which is gross and dangerous. And then there's also tracheostomy methods here and here. Again, these are, I have 2 infants or young children here, but it's also totally fine for school-age kids, teens and young adults. And then just a note, this guy is one of my colleagues at Nationwide Children's, Dr. Richard Schaub. He let me use that photo of him. Let's see. Okay, I think this is toward the end here. We also have to think about what I call non-pulmonary issues. I'm a little self-centered about my specialty, and I think that everything is a pulmonary issue, and I want to take care of those things. But this is outside of the lungs. So if you have heart disease associated with your neuromuscular condition, that can definitely be impacted by your respiratory support and your respiratory disease. And your respiratory disease can be affected by heart dysfunction as well. So we have to pay close attention to that. We talked a little bit about scoliosis. Scoliosis can be corrected. We can fuse the spine or use magic rods to help the spine grow straight. But we know that lung function doesn't recover when we fix the scoliosis. We don't exactly know why. We haven't figured out what the muscle issue there is. But we know that we don't recover lung function. We only hope to prevent further losses of lung function that would have been due to scoliosis. Aspiration is a big problem to think about. And I think of it in 2 ways. Aspiration can lead to acute breathing problems. You drink a glass of water, goes down into your lungs, that can cause problems. Or subtle aspiration over time can cause an accumulation of airway injury that eventually leads to lung disease and breathing difficulties. And so if we get a swallow study that shows silent aspiration, but the kid is fine or the young adult is fine, then we still have to talk about what does this mean for 5 years down the road, 10 years, 20 years down the road. We still need to pay attention to that. And then finally, constipation, big issue in many of our patients, can push up on the diaphragm and limit chest wall movement. And oftentimes what I see is I just keep cranking up the BiPAP pressures and nothing is happening. And people are just getting more and more uncomfortable. So we really have to treat constipation too. So here's a summary. Breathing problems vary by the specific diagnosis. The history and exam are crucial, so I pay very close attention to how the chest moves and in different positions. Pulmonary function and other tests are very helpful in further refining how we think about respiratory function. I think you should see a pulmonologist early, and you need an experienced respiratory therapist and pulmonologist on your team. Depending on your diagnosis, you may not need us often or for a lot of support, but it's best to find that out just by visiting us. That's not just a plug for my business, that's actually a plug for your health. And I think that's all I've got. I'm happy to take some questions.
Thank you very much, Dr. Kupfer. I was curious, do people use the cough assist with the vest, or do you use one more as a tool to kind of, as a management of the mucus so it doesn't get to a certain point?
Yeah, so we tend to use cough assist more than anything else, because the issue in respiratory muscle weakness, again, is you can't expel that mucus. There shouldn't be a problem with the mucus itself being too sticky, like in cystic fibrosis. And so, so I don't start with a vest. The other issue is that through some insurances, it's quite difficult to get both devices. And so if I had to have one, I'm going to choose cough assist every time. Some people will tell me, but the vest works so much better. It's like, yeah, because you can feel the stuff moving up. And then they're admittedly absolutely true. There are patients for whom vest plus cough assist works best, and then I go to bat for them. That's what we need to do. It keeps you out of the hospital. Great, we'll do that. But we always start first with cough assist.
Okay. This person typed in, my child has CMD on AVAPS using Trilogy.
Mm-hmm.
She destats when flying, so we use it in flight. Is there an elevation we need to stay away from?
That's a great question, and I'm a fan of AVAPS. That's a kind of a personal practice. So I use it quite comfortably, and I work at altitude. So
you are in Colorado.
Yeah, we're a mile high. Airplanes are pressurized to about 7,000 or 8,000 feet, so they're a little higher than us. In children who don't have actual lung tissue disease, they just have respiratory muscle weakness, they shouldn't have desaturations going to altitude, which is like if you're driving over a mountain pass here in Colorado, you'd essentially be at the same altitude as you were in an airplane. You shouldn't have desaturations. So it may be that that's a subtle sign that that settings may need to be adjusted. The other thing that happens at altitude is that we all breathe a little bit faster. And so it may be that instead of changing settings or changing pressure settings, the setting that might need to be adjusted for flying is the respiratory rate on the device. That's something to talk to your pulmonologist about.
She's also wanting to know, do you keep them on a SAT monitor for life?
So this is in the case of someone who's on non-invasive ventilation?
Yes, that's the same person who you're just talking about. Yeah.
So I tend to have most of my patients who are on non-invasive ventilation at night on a monitor, but you don't have to. If they're sick, absolutely I do, because it can be a warning sign. A low oxygen level can be a warning sign of getting worse. For babies, I tend to do it just because they have less ability to communicate with us if they're not feeling well. Young adults and teens, I tend not to, because it's more of a torture device. It's one more thing tying you down. So I tend not to. And then anybody who's on chronic ventilation 24/7, either invasive or non-invasive, I
Mhm.
tend to use the pulse oximeter a little bit more aggressively.
Okay. Another question. My child has myasthenia gravis, asthma, dysphagia, and scoliosis. Are all pulmonologists created equal? That's a lot.
um, that I I'm not going to answer the question about uh, which pulmonologist you should see,
Sure. Okay.
but I think you should try to find a pulmonologist who knows about neuromuscular disorders. All those things can create kind of a perfect storm. And so
Uh-huh.
you need someone who thinks about respiratory muscles as well as asthma and as well as scoliosis.
Okay. All right. I do not see any other questions that have come up. So thank you very much, Dr. Cooper, for your time and for your presentation today.
Yeah, thank you. This was a pleasure.